I'm Brett Youngerman. I'm a neurosurgeon in the Center for Movement Disorder Surgery at Columbia University and New York Presbyterian Hospital. And I'm going to be speaking about neurosurgical interventions for Parkinson's disease. We'll start off by talking about deep brain stimulation, which has been the mainstay for many years. So just as an introduction, this procedure involves the placement of a thin wire known as the lead or electrode into a specific brain region. We then connect this to a pacemaker-like device in the upper chest, and stimulation delivered through this device restores normal electrical activity in the brain. The idea is that there's no permanent lesion that is made, and the therapy is adjustable and programmable over time. DBS, or deep brain stimulation, has been around for many years now. It was first approved for tremor, both in Parkinson's disease and an essential tremor in 1997. It was then approved for advanced Parkinson's symptoms in 2002. And in 2016, it was approved for earlier stages of Parkinson's, and we'll get into that distinction in a little bit. It is also approved for other movement disorders such as dystonia, as well as obsessive compulsive disorder and epilepsy. And there's a lot of ongoing research that you might hear about for other indications for deep brain stimulation. Who is a candidate for DBS? So generally speaking, we say symptoms for at least 4 years, though that's something that is not a hard stop, but is something that we generally aim for and is based on the initial FDA pivotal trial. Symptoms that interfere with daily activities. Tremor that doesn't respond to medications can respond very well to DBS. And then other symptoms of Parkinson's disease, such as slowness and rigidity, that do respond to medication, but perhaps the duration of the response is short or incomplete. Patients are suffering from significant on-off motor fluctuations, or they have dyskinesias on medication, or other medication-related side effects that are limiting the efficacy of medication. So in terms of tremor, the effects can be quite dramatic, and that was the original indication and approval for deep brain stimulation targeting the thalamus. For the other symptoms of Parkinson's disease, for the rigidity, for the bradykinesia, the effects are a little bit more subtle, and we often spend time explaining this to patients in terms of what to expect. So this is sort of a graph of the normal expected course of Parkinson's disease throughout the day in a patient who's been taking medications typically for many years. They may start in a very immobile off period, take their medications, have a mobile on period, but then once the medications hit their peak dose, they often have dyskinesias from excessive medication. And then that cycle continues up and down, on and off throughout the day. What deep brain stimulation does, it doesn't, other than tremor, it doesn't typically improve the symptoms beyond that, which is achieved in the best medication on state, but it allows patients to be in that state for more hours of the day. So there's fewer and less severe off periods, and medication can often be lowered, or dyskinesias can be reduced with deep brain stimulation, such that patients spend many more hours a day in the on period. So which symptoms can DBS help with and which can it not? Traditionally, we say it's primarily for the motor symptoms, and that's what it's approved for, and not for the non-motor symptoms, but it's actually a little bit more subtle than that. So the motor symptoms that it's most helpful with, tremor, as we've mentioned, rigidity or stiffness, bradykinesia, slowness of movement. But some of the non-motor symptoms can actually be helped as well, either directly from the effects of deep brain stimulation or indirectly through medication reduction. These include things like problems with sleep, pain, orthostatic hypotension, and constipation. And DBS does not help with many of the traditional non-motor symptoms, such as cognitive impairment, depression, apathy, impulse control disorders. There's also some of the motor symptoms that it does not help particularly well with, such as postural instability and freezing of gait. So who's not a candidate for DBS? Primarily patients whose main symptoms or complaints are imbalance, walking difficulties or freezing of gait, trouble with speech, daily confusion, disorientation, or significant difficulties with memory, depression, anxiety, or other psychiatric illnesses, as these can be potentially exacerbated with deep brain stimulation. If the diagnosis of Parkinson's disease is in doubt, or it's one of the Parkinson's plus syndromes, that may be something that needs to be taken into consideration. And if patients have other serious health conditions that preclude them from undergoing surgery, that should be considered. So this goes back to the initial study of deep brain stimulation for Parkinson's disease, one of the pivotal studies. And what you see here is that patients, patients were able to achieve more hours of the day on medication without dyskinesias, as shown in the light gray. These are the two different targets for DBS, which we'll get to in a second. This is at baseline. You can see they spend much of the day either in off periods or on periods, but with dyskinesias as side effects. And at 6 months, the patients had a much larger percentage of the day that they were spending on without dyskinesias. How long do these effects last? Well, that's a question that we often get. This is going back all the way to 2003, looking at the 5-year prospective follow-up from that initial pivotal study. And out to 5 years, patients still had significant improvements in motor function, decreases in dopaminergic medications, decreases in dyskinesias, and increases in activities of daily living. Now, of course, Parkinson's disease is still a progressive disease. Deep brain stimulation is not treating that underlying disease. So what was seen in this trial was worsening of some of the symptoms, particularly those that are not treated by DBS between year 1 of follow-up and year 5 of follow-up, because it is still a progressive disease. But patients were still getting benefit compared to their preoperative baseline at 5 years, is the key takeaway here. This was another randomized controlled trial that was done in Germany several years later, again showing similar things. So we see improvements in multiple domains of quality of life in patients who underwent deep brain stimulation: mobility, activities of daily living, emotional well-being, stigma, bodily discomfort. And what we see here, the key marker here is the time in green that patients spent between their baseline and at 6 months follow-up. On average, over 4 hours more a day, mobile without troublesome dyskinesias, compared to actually a decline that was seen in the medication only group. And we talked about initially DBS was approved for advanced stages of Parkinson's disease, and I think a lot of people still have a bias and think of it that way. But actually, there was a very important study over 10 years ago now that showed DBS to be effective in earlier stages of Parkinson's disease. So this was for patients who had at least 4 years disease duration. Patients in that group actually had a mean duration of 7.5 years of their Parkinson's, and the mean age was 52 years. And these patients had significant improvement in their quality of life, as you see in the top graph here, and in many domains of quality of life, similar to what was previously shown in the advanced stages of Parkinson's disease. DBS is not actually a monotherapy in that there's multiple targets that we can choose from. So when we talk specifically about treating essential tremor, we're typically targeting the VIM thalamus. The two main targets that are used in Parkinson's disease are the subthalamic nucleus and the globus pallidus. There's been a lot of focus over the years, a lot of research to try and tease apart which one is better for whom. And the long and short of it, this is a summary that came out of guidelines several years ago. Either target will work well for the motor symptoms as measured by the EPDRS. Either target will work well for overall improvement of quality of life. So there's not really a wrong answer necessarily here. But if the goal of deep brain stimulation is to reduce the dopaminergic medications, the subthalamic nucleus may be the better target. If the goal is to reduce on medication dyskinesias without necessarily actually reducing those medications, then the globus pallidus might be the better target. This review also did find that if there's significant concern about either cognitive decline or significant concern about the risk of depression, then the globus pallidus may be a better target, although this is not something that everybody necessarily adheres to at this stage. Adverse events beyond that were not significantly different between both groups, but this is part of a comprehensive evaluation with the team that will aim to select the best target and make a recommendation for each patient on an individualized basis. So speaking of the evaluation process, what does it involve? It's typically 2 to 3 visits over the course of at least 1 month at a minimum. Often it does stretch out longer than that. Seeing one of the movement disorders neurologists who are familiar with deep brain stimulation. They will do on-off testing in the office where patients come in off their medications, get the UPDRS, take their medications, and get examined in the on state so we can see what the response is to medication. And that can help us determine candidacy for DBS and also whether or not which target we should be selecting for each patient. A consult with the neurosurgeon, an evaluation by the neuropsychologist to make sure there's not contraindications to deep brain stimulation, An MRI of the brain, which is part of the diagnostic workup, but that MRI is also necessary for surgical planning. And then, of course, a medical evaluation and clearance for anesthesia and surgery. So what's actually involved in the deep brain stimulation procedure? We typically think of it in two stages, although we're often doing them in a single surgery at this point. The first stage is where we're actually trying to put the electrode into the brain, and we're aiming to put a very small electrode that's only a little over 1 millimeter in diameter down to a target that in some cases is only about 4 millimeters. So it's a very precise procedure. This is just a close-up look of what that electrode actually looks like. We're able to achieve this with a combination of different technologies. So this starts with planning based on that specialized MRI that I mentioned. And then we actually bring that plan into the operating room where we obtain a CT with a special fiducial box on the patient's head. And then by merging those images together, we're able to basically bring that plan into the operating room and essentially have a GPS system that's customized to that patient's brain and head. We then use various stereotactic systems to actually line up and recreate that trajectory in real space. Typically, that involves a ring and arc system, such as the one you see on the left here. More recently, we've been adopting a robotic surgical assistant. The surgery is still done by the surgeon, but the surgical assistant allows us to line up that trajectory precisely and efficiency while eliminating sources of potential human error, and also cutting down on the total surgical time. Microelectrorecording is something that's been traditionally used and that we still like to use to confirm the electrode placement. Different areas of the brain have different electrical signatures, and so as we pass the electrode down through the brain, we can characterize those electrical signatures, and that allows us to confirm that we're actually in the right spot in the brain. And then once we're in the right spot, the traditional way of doing this procedure is with awake stimulation testing. So patients are kept asleep for everything up until now to actually keep them comfortable. They don't have to experience any part of the surgery, but then patients are actually woken up during the surgical procedure. They don't feel pain. There's still anesthesia on board. There's local numbing medication, and they're able to participate. And that way, one of our movement disorders neurologists is actually there in the operating room, does the testing to make sure that we're getting the effect that we want on the Parkinson's symptoms, and that we're not having off-target stimulation side effects. Now, I will say that over the years, more and more centers are considering, and we've done as well, moving away from the awake testing, which can be intimidating for patients. And this is some data from multiple studies that have been done over the years showing that the awake testing is no longer absolutely critical. And that is likely due to a combination of improvements in our surgical targeting and also due to some improvements in the technology. So it used to be that once we put an electrode in, it was either in the right spot or it wasn't, and it would be turned on and off. And it would just create a sphere of electricity, a small stimulation in that area of the brain, and we were kind of stuck with what we got. Now, with the newer technology, we have what's called directional stimulation or steered current. And so the stimulation can actually be shaped to create different spheres of influence that it has within the brain. And what this allows us to do is direct the stimulation towards the target, which in this case is showing in green as the subthalamic nucleus, and minimize the stimulation that's being received by other areas of the brain nearby. This allows us to have fewer side effects. It allows us to, we say, increase the therapeutic window, meaning we can go up to higher levels of stimulation to get the effect that we want without having side effects. And it also has likely resulted in the need for fewer revision surgeries over time to revise the placement of the electrode. From there, we then move on to the second stage of the surgery. Again, traditionally, this was done in two different surgeries, often a week apart. At this point, we're doing this largely in one surgery, thanks to improvements in efficiency and working with our neuroanesthesia team. So the second stage of the surgery, patient is completely asleep no need for participation here. And this is where we're putting in the extension wire and the pulse generator, which is the pacemaker-like device in the chest. All these wires are fully implanted and under the skin at the end of this surgery. Patients typically then spend one night in the hospital, go home the first day after surgery. We actually typically do not turn the device on right away. We allow patients to recover, get back to their usual medication regimen, their usual symptoms, and then they'll go into the office and begin the DBS programming process, which can involve multiple sessions over the course of several months to fine-tune the effects, and then also maintenance sessions over time to make programming adjustments as needed to adjust to the state of the disease. There's been a lot of advances in the technology over the last several years that is really to the benefit of our patients. So these include rechargeable battery. Traditionally, patients had to have a replacement surgery every 3 to 5 years, and that's still something that many patients choose, but there's also now an option for rechargeable, which through a wireless wearable device that has to be worn on average about an hour a week to recharge the device. There's a patient controller that they get at home that allows them to see the battery, select different settings at different times for different circumstances. We now have brain sensing, which allows us to actually look at the electrical activity in the brain from the device itself. That allows us to select the right contacts and the right settings for programming, and allows us to actually monitor in an objective way how the brain is responding to deep brain stimulation over time. We have a feature from one of the manufacturers that actually allows remote telehealth programming where the device can be accessed over Bluetooth without even having to come into the office. This is best for the maintenance programming. For the initial programming sessions, we typically still have patients come into the office. Surgical risks of the procedure, we talk about temporary confusion in 5 to 10% of patients, almost always resolved by about 2 weeks after surgery. We talked about brain electrode revisions, far fewer necessary these days thanks to improved targeting and directional stimulation. The most serious complications are thankfully quite rare. These are infection or skin erosion, which is around 1%, and a brain bleed or stroke, which is around 1 in 200 surgeries, which is significantly improved over time. We talked a little bit before about the side effects of stimulation, most of which these days are avoidable with that directional stimulation. And then I briefly want to move, of course, to the newer technology, which is focused ultrasound. This is a totally different approach whereby we use ultrasound waves, many hundreds of small beams of ultrasound waves, all focused on a single point to actually make a lesion or ablation in the brain. And this was the traditional way of actually doing deep brain stimulation, of actually doing surgery for Parkinson's disease before deep brain stimulation existed. Deep brain stimulation largely replaced that surgical approach, but now with focused ultrasound, we can actually do this completely non-invasively without any incisions. This is FDA approved for unilateral thalamotomy for the treatment of both essential tremor and tremor-dominant Parkinson's disease. This was the pivotal study in the New England Journal in 2016, which basically showed that patients had significant improvement in their tremor. Adverse events, there were quite substantial immediately after surgery, but few and well tolerated when you get out to 12 months. The main limitation here is unilateral surgery. What about focused ultrasound for the other targets that we're using for Parkinson's disease beyond just tremor? Well, this is pallidotomy targeting the globus pallidus. And here this showed very promising results, 69% response rate when we look at the UPDRS and dyskinesias, relatively well tolerated in terms of side effects. And this is being pretty widely adopted at this point for unilateral treatment, again, for one-sided treatment for symptoms, and also for unilateral treatment. Move on to, and then subthalamotomy is the last target that's being considered. This was recently published as well in New England Journal. A little bit more concerning on the side effects here, so still some work and some controversy about this procedure. So I'll just wrap up with deep brain stimulation versus focused ultrasound. It's not an either or which one's better, it's which one is better for who. So DBS is programmable stimulation, it's adjustable, it's reversible. Focused ultrasound is a permanent ablation in the brain. DBS we can do bilaterally or unilaterally. Focused ultrasound, for the most part, because of the concern for side effects and because we are making ablation, is typically just used to treat one side. Although there's going to be some results coming out not too distant future, looking at staged approaches to bilateral treatment, at least at this stage for a tremor, not yet for other Parkinson's symptoms. DBS, minimal head shave just at the sites of the incisions. Focused ultrasound is a complete head shave at this stage with the current technology. Deep brain stimulation, though, more invasive, multiple incisions done in the OR with anesthesia. It requires a hospital admission. There's risk of bleeding, there's risk of infection, although small, they are still there. And we have to hold anticoagulation and antiplatelet medications. Focused ultrasound, on the other hand, less invasive, no incisions. It's done in the MRI without anesthesia. It's an ambulatory procedure. Patients go home the same day. There's minimal risk of bleeding or infection, and patients can potentially even continue their antiplatelet and anticoagulation medications, so this is an area of active study. Finally, DBS requires maintenance and programming visits to program the device. It's an immediate, whereas focused ultrasound has an immediate result, and there's less follow-up that is needed. My last slide, looking at future directions. Adaptive deep brain stimulation is an area of investigation where we can actually use the sensing on the device to adjust the stimulation in response to the activity in the brain throughout the day to try and automatically keep up with the patient's symptoms. Focused ultrasound, we mentioned staged bilateral procedures that are being explored, also other targets for specific symptoms within Parkinson's disease. Gene therapy, I'll make a special note of the fact that we've got a trial at NYP, at both Cornell with Dr. Caplet and at Columbia with Dr. Baltuck, looking at a gene therapy approach, which has the potential to actually be disease modifying, unlike both either DBS or focused ultrasound, which are treating symptoms. Cell replacement therapy is something that's been looked at for years, but there's ongoing trials with a lot of promise in that area right now. And immunotherapy is probably the most recent area of investigation. So with that, I will wrap up, and I just want to acknowledge our team at New York Presbyterian and the Columbia Movement Disorder Surgery Center. Thank you very much, and I'll take any questions.